Thank you very much. I come here to receive my annual vitamin D, and I'd like to thank the colleagues who are here, because in spite of the nice weather outside, Ayhan Algül and Köksal Alptekin talked about many of them, but I will show you my slides. I worked all night to prepare them. This question looks a little difficult, but is the glass half full or half empty? Using antipsychotics in the long term, is it beneficial or is it risky? Now this is simple. Let me show you a few slides and you will decide for yourself. First of all, we should do no harm to the patient, coming from Hippocrates. And clinical pharmacology, the main fundamentals we did not receive when I was a med student, and we learned them on our own in time. If we had that foundation, then it would be better. Now there is this école about rational prescribing. The boss used to be doctor. You write the prescription, you give them and send them away. The patient couldn't say anything. Now the patient is the boss. Patient rights have surpassed doctor's rights. So the approach has changed. Actually, I'm for the second. They are the ones who buy and use the drugs. They see the side effects, so it's trial and error, so they should have this right. There are two concepts for the younger fellows here. We need to know the therapeutic index, what it is in terms of clinical psychology, and the risk and benefit ratio we need to bear in mind as well. The risk and benefit ratio, if we understand this properly, then it is easier for us to decide and to know what we're doing when we're talking with the patient. So I worked for hours last night to prepare this slide. So on the right side we have therapeutic gain and left side adverse effects. And this we call high therapeutic index. The drug we prescribe is effective. This one is the best. The previous one is not enough. If this is the outlook, namely if the therapeutic gain is marked and the adverse effects are mild, this is high therapeutic index. We need to find this drug which gives us this outlook. And actually I draw this diagram to the patients and their families when I'm talking with them. Now we receive the patient. This one is moderate, this one is moderate, so they are balanced. But when it's like this, so we are worried if it's enough or not. And this one is unacceptable. With a minor therapeutic gain and severe adverse effect, this is unacceptable. And this one is harmful to the patient, the serious side effects. And if this is the picture, then this is called the low therapeutic index drug, and we should avoid using such drugs. Rational prescribing should be based on 4 objectives: to maximize effectiveness, to minimize risks, to respect patient choice, and because the patient is the one who's buying it, the patient should know all of these and then ask a specific drug. And then you tell the patient, I told you this adverse effect, but you chose it, and We use it a lot that way, and of course the cost is important too, since Canada is rich and it's no much problem. So how to do? How can we define efficacy briefly for schizophrenia? We need to know the concept. How to find it? I don't know the details. I check only these 4 criteria. PANS, all the specialists, all the students and assistants, positive and negative symptom scale, they should be knowledgeable about it. If the total PANS is 80, they should know what it means. Does it mean if it's 100? What does it mean if it's 60%? Another one is response to treatment. So the assistants talk to the professors. They say the patient is responding to treatment. Yes, but what does it actually mean? It doesn't really tell much. So we need an NT numbers needed to treat. It will be much better. Another concept is remission, and the best one is, as Ayhan they showed, systematic reviews to check their effect size. I'll show you one thing, the effect size. This is it, and here is a definition. The electroconvulsive therapy, what's the effect size? Could someone tell me? The best antidepressant is ECT, right? ECT has around 7.5 to 8%. This is the most effective antidepressant. And this is how we talk about it among us. So 0.2 is very, very weak. 0.4, 0.5, not bad. But if it's above 0.8, then we're not worried. So and we can use it and we can teach it to the patients. And thanks to Dr. Google, the patient is going to look everything up, and so it doesn't really matter what you tell them. So they say, okay, I'll buy this, or they say, you forgot to tell this, so we have to be more careful. So based on meta-analysis, and since Rayhan Algül preempted most of my presentation, says that if the doses are used correctly, all of those drugs are same, almost same, based on effect. And this is maybe something you should take away from this presentation. Looking at the effect size, clozapine is 0.5. Do you have amisulpride here? Yes, but nobody's using it. 0.3, nobody's using it. And the French drugs, they have good drugs, but the French cannot enter the larger studies of the Anglo-Saxons. And risperidone 0.25, olanzapine 0.2, but this is not high, we're going downwards. On all the other second generation antipsychotics are all below 0.2, so unfortunately we can't review them strongly. So the effect size is important. Patient choice is important. Like I told you, with every patient we see, we take time to sit together to explain to them what are the pros and cons, and we have to explain everything thoroughly, because otherwise they are looking it up on the internet and they will do wrong things, they will discontinue. And looking at the guidelines, we see that the health professionals should provide accessible information about schizophrenia and its treatment, to what is the treatment plan and the dosages and the side effects. They should review them together and make an informed decision together with the patients. And when we are writing our clinical notes, we're taking a note of everything, and we say the patient consented. I explain the side effects, and we write down everything. In case of any problem, the lawyers are going to check all those notes. And so these are important. I mean, we already do it, but we also have to make notes of them. And now briefly, let's talk about the risk-benefit issue, the risk-benefit ratio in schizophrenia. In the treatment of the patient, in the treatment for the patient, should I prescribe treatment or not? If the patient is it's an internal patient, or in the emergency you see the patient, and if I don't treat this patient, if I send them back, what will happen? Is there a risk to the patient? Is there a risk to their family or to any other carers? And is there any risk to hospital staff, to other care providers, or any risk to society? Maybe he took the bus and he got into a fight with the driver, so we have to review it, and then we have to make a decision, and we will have to make a detailed note and report of it. After that, then we can review the side effects of some drugs. Some drugs have a lot of adverse effects, like clozapine, but in spite of the side effects, sometimes we can prescribe clozapine. And if we don't treat the patient, these are the risks associated with not treating schizophrenia: the worsening of illness, increased distress to patient, distress to family, carriers, deterioration of physical health, and functional deterioration, and many other social problems could be created. And the question here is this: do the risks associated with antipsychotic treatment greatly outweigh the risks of failure to engage the patient in treatment? It's not just the patient, but we have to think about the other players as well. For example, a psychotic patient has commanding type hallucination. The sounds can say, "Go kill him, shoot him," and then he goes, commits a crime. You might be held responsible for it, the doctor, and you can be. And if you wrote it down, and if the patient's relative said, "We went to the doctor yesterday, we told him about these sounds, he did not do anything, so I believe the sounds," in that case the doctor will have to stand in front of a judge. The most important side effect is EPS, weight gain, sexual dysfunction, and sedation. Let me skip those two. The hematological, libido, dermatological antipsychotics have adverse effects related to all parts of the body almost. They're not just mild drugs. And now we have to tell the patient all of them, otherwise they will look it up on internet and they will show it to you, so it's very embarrassing, and the Google has changed our way of doing our jobs. And in summary, the risk-benefit considerations should underpin all treatment decisions. We have to know the effect size of all drugs. And I think these were explained by previous speakers. What's the outcome in schizophrenia? In schizophrenic patients, there is very little hope of recovery, and in North Norway, only 6 patients are reported to have recovered fully after schizophrenia diagnosis, and I thought maybe their diagnosis was wrong. Then I thought, these people eating fish 3 times a day, so maybe omega-3 is infused in them, and I still don't know what really happened, and I just know that the only publication with such recovery came from Norway, with 6 people recovering from schizophrenia in a village in northern part of Norway. So everybody accepts that schizophrenia is a lifelong illness, and based on any data you might check. And does antipsychotic medication change the course of the illness? That's a very important question, actually. We make a lot of efforts. Does it change the course of the illness? There are so many studies on that, and the conclusion is that there is a limited impact of antipsychotics on outcome. So it's not a cure, it's like a symptom repression. It increases quality of life, it has limited effect. This was said by previous speakers. I think there is not a definite clinical trial. How long to continue after first episode? I wish somebody told me. 6 months, 1 year, 2 years, 3 years. I don't know the answer. Even there is a controversy, disagreement between European and American psychiatrists, because there is not a major study on that. What I do is, let me tell you what I do. I put the patients on remission in 1 year. I see all the family members. They tell me for 6 months there is no symptoms. Our son, our daughter has come back to us. 6 months, full remission. And then they start recovery, and then I slightly lower the dose. Since we use long-acting injectables, I slightly lower it, then I wait for 3 months, 6 months. So I do not discontinue suddenly. Sometimes it's 2 years, sometimes 3 years. Sometimes when I slightly lower the dose, the patient's relatives are very concerned. They're afraid that the patient is going to get worse again. So this is still quite unclear, and let me be honest with you, unfortunately in many cases the patients are going to discontinue their medication. They suddenly stop and go toward alcohol or substance abuse, and then they come to the hospital with full syndromal psychotic, and comes an automatic diagnosis and a lifelong illness. So it's what happens in 50-60% of the cases. So does antipsychotic medication prevent relapse? It absolutely does. In the clinic, we use long-acting antipsychotics, the injectables, and there is definitely an effect. If you stop antipsychotic, everybody goes into relapse. It's about 53%. But if you continue, even at low doses, relapses may go down as low as 16%. So I support continuing even at low doses. So is the risk of relapse lower with depot preparations compared with oral medication? Which one is better? I showed you the old trial to be objective, and drug companies are not giving any promotional materials, pens outside, so I am impartial now. Depot fluphenazine and oral fluphenazine. So in patients who are prescribed depot fluphenazine, the relapse is very low. In oral fluphenazine, almost everybody is going into relapse. So injectable, definitely injectable is good. We will see, I think, one injectable antipsychotic per year. I think we will see it in the future. Let's skip this one. This is rehospitalization at 1 year for first generation antipsychotics and second generation antipsychotics. It's again protecting, but there is a difference. And this is the final question. Is maintenance medication for relapse prevention required for all patients with schizophrenia? Remember my first part, we reviewed the risk-benefit ratio. We will do the rational prescribing, and to be honest, when you check the publications, there is not a 30-40 year trial. There are 10-year trials maybe, but they're weak. You have all those studies, guidelines, but the recommendation is long-term maintenance despite lack of evidence. Definitely, this is what we do. And even we talked about 1 or 2 years, and this one says 3 years after the first attack. Treatment must continue for up to 3 years. There is this kind of a gap here. That's why we need to get feedback from experienced professors, psychiatrists.